those days, like it is in 2006, 2005, 2006, we used to have around 10 kidneys a year. So very less number of deceased donor transplant. And then there was no liver transplant program in the state. Then one day I received a phone call from Surat. There was a 61-year-old brain dead donor, and the family, his children were staying in United States. They all came to see his father's last time, and then they decided to donate the organ. So now Surat was around 250 kilometers from Ahmedabad, and there was no transplant center there. So somehow they found out my phone number, called me, and then requested to procure the organ. So I went there after taking due permissions from the government, because I'm working in a government institution. So took the permission from director and then the health secretary at that time, and went and procured kidneys. Then it was expectations were raised. Surat was the city where exactly more number of deceased donors were available. And we started that journey more frequently. So looking at that, there was a gastroenterologist named Dr. Rajiv Mehta. He studied at Kochi, and he worked for a while in a liver transplant unit also at Hyderabad. So he asked, can we use the other organs as well? But then the government permission was required, especially to transport the organ from Gujarat to other state. And at that time, then Health Minister, Mr. Ashok Bhatt, he gave the permission that yes, that can be done. So a team from Kamayanini Hospital, Hyderabad, used to come and procure a few liver. So they used to come by chartered flight from Hyderabad to Mumbai in those days. And Mumbai to Surat was a taxi journey. And while returning in the same way, so Surat is in the middle between the Ahmedabad to Mumbai. So by the time they come to Mumbai, we start from Ahmedabad, and then we reach almost simultaneously, and then procure the organs. I took the kidneys from my side, and then they used to take the liver. So 4 or 5 occasions, such type of things has happened. Then one day, the Hyderabad team was stuck in traffic for several hours. It was a very heavy traffic between Mumbai to Surat. And by that time, the donor deteriorated to the extent that the output was nil. She was on a multiple vasopressure, etc. So then the donor team arrived. By that time, we were not sure whether we will use kidneys or not. Then the donor team arrived, and we procured the organs. They were happy with that kind of liver also. And then in change room, I asked to the surgeon, principal surgeon, can it be possible that we procure the liver and send it to Hyderabad rather than you come all the way from this and then to send it? And there was a little unacceptable answer. He said that it's very special procedure to procure the liver, and if you do this, I will not use such type of liver, in a little rough language. That hurted us. So as soon as I came back to Ahmedabad, IKDRC, I talked to my director that there is nothing very special for any surgery in the world. And if I can do, somebody else can do. And if somebody else can do, even I can do. That is very simple thing. So I would like to train myself in a liver transplantation. The best part of my director was he was passionate for all kind of transplantation.
Who's your director that time?
Dr. H.L. Trivedi. He himself was a nephrologist, and he is a pioneer of the founder director of Kidney Institute. That is right now it is known as Institute of Kidney Disease and Research Center, and Dr. H.L. Trivedi Institute of Transplantation Sciences. So he was very passionate, and he thought for a while and said, yes, let us see how we can make it possible. That was the year.
This was which year? This was which year?
It was in 2006. Year 2006. In the same year, the IKDRC completed its 25 years. So we had a silver jubilee celebration, and we requested Indian Society of Organ Transplant meeting to host at our institution. And so yes, ISOT has accepted it, and we called Professor Carl Gustav Groth, eminent liver transplant surgeon, and he was the chairman of a Nobel committee for 20 years at Stockholm. So he accepted our invitation to come to India and to see the program. Then who will pick him up from the airport? So that was the discussion going on in our internal meeting. And Dr. Trivedi asked that, yes, you go, you are a surgeon, and you will talk better with the surgical team. So surgeon who is coming, and he is a very eminent person. So I went there to pick him up, and while traveling, I asked him that, how can you help? We have a few deceased donor here. We don't have a very big deceased donor program in Gujarat, but we are wasting the liver because most of the time only it is the Surat which was possible. Other places it was not possible to use the liver. Then he said that you should transport the liver from here to Delhi or some other place. I said, yes, logistics are not easy because we didn't have flights, so frequent flights in those time, right? Which is now currently it is available, but in those days it was not so. And it is, there are 1 or 2 flights a day, and then we can't adjust the organ procurement every time accordingly. So he asked me, what do you want? I said, I want training in deceased donor liver transplant program. So he just smiled, and at the end of the meeting at ISOT, he asked my director that send this boy to me and I will be training him. I will put him in Karolinska University Hospital. So my director said that, yes, you take him, that's not a problem. And he also wishes to go. I also want somebody to do the liver transplant. But at the same time, what will he do once he come back? There is no anesthesia training, there is no other training, and there is no assistant to him. So better you take 2 surgeons and 2 anesthetists to train. So not a 1 person, but a team. And that's how this has happened somewhere in October 2006. And by February 2007, we were at Stockholm. So there, Professor Göran Eriksson, he was a chief transplant surgeon at Karolinska University Hospital, Huddinge.
What is the name?
And,
name again? Sorry.
Pardon?
What is the name that you're talking about? Name?
Yeah, Professor Göran Eriksson.
Bjoran.
You spell it like Bjoran, B-O-O-R-A, sorry, B-O-G-O-R-A-N, B-O-G-O-R-A-N.
Okay.
Right. And there are 2 dots on the O. So the pronunciation is Bjoran. Okay. Otherwise, in English, we can say Bo Goran.
Okay.
Right. So Professor Bjoran has accepted us, and same thing is in anesthesia. There was Professor Ellie Boy. I don't remember exactly the spelling of his name because in Swedish they write out a little different. The pronunciation is different than the what they write it down. And they trained us and they allow us for every aspect of transplant. The language was a major barrier because they all knew English, but then they hardly speak in English. They used to talk only in Swedish. So that was a major issue. But then they gave us the office to read, computer, everything they provided to us that we used to read. And then we procured the organ going to some islands, even Gothenburg and other places where the transplant program is there. So there was a lot of roaming around also, and procurement, the bank surgery, the actual assisting as a first assistant in a transplantation surgery, everything was possible. And same thing with the anesthetist. So we had it was planned that I will work for 2 years there. But I realized that working for 2 years will be too long and it may not be so much necessary. And language was a very major barrier. So we need to do something and I had enough reading by that time. So we returned to India within 6 months of time. Now we wanted to set up.
Who was there with you? Like, who was the other surgeon with you?
Yeah, correct. Dr. Bharti was there with me, but she left after 2 months and she returned back to India because the institution wanted her also for some reason. And Dr. Guru Prasad Bhosle and Dr. Veena Shah, they were the anesthetists. Dr. Veena Shah was professor and head of department of anesthesiology at my institution. And Dr. Guru Prasad was young chap, young assistant professor, and then he opted for the training. So out of four, three remain, and then we return after about 6 months. So once we return here, then the director said that I don't have so much of money to start the transplant program soon. So I was back to the urology and kidney transplantation. I'm a principal urologist and doing a lot of kidney transplant as well. So for 11 months, there was just we plan out and procured the equipments and etc. And in a government institution, it's not that easy to do all those things, but it's an autonomous institution and director has used its discretionary powers, and then we got all retractors and all other equipments, vascular equipments and other things. So including the anesthesia trolley and so many things, rapid infusion system, etc., like PG, nothing was there otherwise before we started the liver transplant program. Then who will come to me? My credentiality was as a urologist and kidney transplant surgeon. Then who will come to me as a liver transplant? And also 11 months passed like that. Even I was also losing some of the confidences because you forget, if you don't do the procedure, you forget so many things also. But I just keep on reading about Bushutil and the other hepatology, some of the books like that, and intermittently. And then a local writer, Gujarati writer, wrote a story in a local newspaper that he was writing a life story of Dr. Trivedi, H.L. Trivedi. So in that he wrote that Dr. Trivedi sent a team to Karolinska to learn the liver transplant, and now the team returned and they are fully equipped and they are ready to do the transplant. So reading that in a vernacular newspaper, local newspaper, and a patient came, first patient came, and she had a hepatitis C related cirrhosis of liver. She had undergone cesarean section, blood transfusion was given, and then since then she had hepatitis C virus. And then we all know we didn't have the much medicine at that time. So she had an end organ failure, and he had a son and a daughter, but they were not interested in donating the organ. So they initially went to Dr. Rela also, but then somehow they found it's not possible, viable for them financially and many other ways. So they returned to Gujarat, and they approached me and then say, what was the cost of the transplant? I was not knowing what is the cost of transplant. So I asked Dr. Trivedi. He said that you just do it, it will be free. Right? We want whatever expenditure is there, we want first transplant to happen like that. So I said it's fine. And then we got a decision. I was not having any concept of living donor transplant because in Karolinska it was only deceased donor transplant at that time. They did a couple of split transplant, but I was not very sure that I can perform such type of things. So then there was a deceased donor at Rajkot, first case like that. And then I procured the organ, came back, transplanted, and it was nice for about 12 days. The patient was, everything was fine, but on 12th day, patient developed pneumonitis, severe pneumonitis bilaterally. And it was bacterial pneumonitis, and then she succumbed. So it has shown that yes, first patient was lost, and then it was so shocking thing for all of us that you could do the transplant technically, but then patient did not come out of the intensive care unit.
So this was in 2008.
Pardon?
This was in 2008.
This has happened in 2008. Yes, this has happened in 2008. It was the 28th of May, first liver transplant, which I carried out like that. So I was not very, I mean, I was really shocked but Dr. Trivedi encouraged me, don't get like this. This is this usual story in most of the transplant center, right? And you are, I know what you are right now. You don't have assistant, you don't have, and you have to do all alone. Like I used to go procure the organ. Rajkot is 230 kilometers from Ahmedabad city. So going there in midnight, procuring organ, coming back, and then to start the recipient surgery. There are several other issues, cold ischemia time, and like anesthetists give the anesthesia only once I came back after procurement. So there is another 1.5 hour wastage, etc., etc. But then those logistics were not very nicely understood when we started the program and how we can work it out. And I did not have the assistant surgeon also. So I used to have one medical officer with and one urology resident who can help me. And that's how I did a transplant. The second transplant also did not work well. So I was terribly depressed. And then I decided to quit from this program immediately. But then Dr. Trivedi said, don't do that thing, right? We'll do up to 5. Let us just do it. So it was like I remember 7th January 2009. Same Rajkot was having a deceased donor. I procured the organ. God was with me, I believe, because it was a truck transporters strike on that day, and roads were empty. So no traffic. We went within 2.5 hours to Rajkot, procurement in 2.5 hours, and return in 2.5 hours. So it was probably shortest possible time which we had. And then I started doing transplant. By that time, one surgeon joined me, Dr. Vaibhav Sutaria. He joined me, and so together we did. He was a general surgeon, and we did our first transplant, and that was successful transplant. So patient got discharged in 3 weeks time from the hospital, and that was also very interesting. That patient was alcoholic cirrhosis, and he was for 4 months in the hospital. I told him before taking him on table, and I said that, see, my previous 2 transplant did not work, and you have a choice to withdraw, and you are the only patient I have right now in O blood group. It was O blood group. So he said, no, sir, I'm already dead because I can't go even to the toilet. I don't have urine appropriately. I have massive ascites, and then I don't have anybody at home also. He was so very poor economical class. So whatever you want to do, please do it, and try to save me. That patient survived for 6 years, and then he smoked and smoked a lot. He could not leave smoking. And then he developed esophageal malignancy, lower esophagus. He was operated twice, and then after he passed away because of the extensive malignancy, metastatic disease. So that was my first successful transplant. The second transplant, immediately after that, I did a pediatric patient who had was 16-year-old boy who had a hepatitis B, vertical transmission of hepatitis B virus. He developed cirrhosis, and now that I got a 76-year-old liver. What to do? I did not have hepatologist. I did not have gastroenterologist. Whatever little bit of knowledge I had to to manage these patients, we used to do that. And I procured the organ and transplanted. He survived for 8 years. That was and later on he developed graft failure, chronic rejection kind of things. And then he was taking intermittently medicines because of the poverty. He was not able to, and in those days there were no government scheme where everything was available free of charge. It was difficult for him to buy tacrolimus, generic tacrolimus also. Forget about the standard branded things about it.
So what do you do about the immunization, that Hep B immunoglobulin? Did you use that, or you
we just give entecavir only, nothing else in those days. Later on, the immunoglobulins were made available in our store also, because till that time we were not knowing also that in emergency we have to do transplant and we'll require so many, so expensive medications like immunoglobulin and other things. But we gave him he was on antiviral therapy by the gastroenterologist, and we continued the same thing. And then he did not have, interestingly, like in end time, we didn't detect in the viral copy later on also in a follow-up period. But that was just a beginning of the program. Like first 2 transplant out of 4, first 2 patients passed away. Second, then after the program started, few patients we had a success, few patients did not have success, and then it has grown. But my focus was mainly on the deceased donor program, like development of it, because it's a challenge in those days. Tamil Nadu by that time introduced this government order, and then they had a pickup of the program. But in Gujarat, we did not have such type of things. And mine is the only government institution where the transplant is going on. In private also, there were not many hospitals who were ready to carry out this liver transplant program, because it was quite expensive. And most of the patients from Gujarat were used to go to either Delhi or to Chennai or Hyderabad or some other places. So they were the big transplant centers, and very reputed surgeons were operating upon there. So then I just keep on running on the 4-wheeler to procure the organs, right? Slowly, with the help of NGO, with the help of my old students, nephrology colleagues, and their contacts with the neurosurgeons, neurophysicians, ICU, etc. We have established a good deceased donor program. So number of cases were increasing day by day. And then the interest of the people have started to establish the liver transplant program in the private hospital also. That if the government hospital can do, then why cannot the private hospital? And liver should be available to them also. So that was the education.
So you did not have any hepatology support in the beginning at all?
No, not at all. Not even gastroenterology.
Your own hepatology? You did your own hepatology?
Correct. That's
all the listing investigations, everything you did.
Everything I followed this Karolinska protocol, whatever investigations like they used to do, I also used to do. And I had a background of a nephrology colleagues transplantation part, like you have a certain immunological investigation. Even like we never used to do the LCM and other things, but in initial part, at Karolinska, they were not doing the lymphocyte cross match and other thing for liver, but here we did it in initial part, because the nephrologists were keen to do certain things about it. So obviously, like what they are doing in kidney, we just interpret, doing in a liver also. But rest of the things like even the triple drug immunosuppression to start with, and all these things we used to do for nephrology. Same thing here, for kidney transplant, same thing we did for the liver also. Later on, realizing that yes, that kidney failure is almost standard after the AKI is a standard after the liver transplant, and so we modified our regimes and medical aspects later on many things after discussion. Then hepatologists has joined to us. That is in a later part of the transplant program. By 2011, however, a pediatric patient came to me. She has a family history of oxalosis. There were 2 sisters, both were suffering from primary hyperoxaluria, and the family, it was a biopsy was taken to UK, and they have proven that there was a primary hyperoxaluria type 1. So I operated that girl child up to 7 years of age, almost for 10 times for stone removal. From the kidney, stone removal, and then she was on dialysis. We didn't have high flux dialysis in those days, so yes, she was maintained. Her rejection fraction was only 25%. It has reduced significantly. Probably there was oxalosis everywhere, and mother said, "I'm ready to donate." Now. It was dilemma for me whether to take the mother's liver or not, and if yes, then who will operate? So I asked them to go to the place where the living donor transplant is going on. They say we can't afford anything because it's too expensive. So again, I went to I decided at that time, I went to Karolinska also, I went to Asan Medical Center. There I stayed there for 1.5 months. At this time, I took my wife also with me, and because she's anesthetist, and she did not want to jump into the liver business because my family would have been, I mean, it's so disturbing things, and especially in deceased donor transplant. But I asked her to help me out, and she agreed ultimately that yes, okay. Then I stayed for 1.5 months, learn the tricks and tips of the living donor liver transplant part, and especially the preservation of the branches of middle hepatic, tributaries of middle hepatic veins. That was they were endorsing a lot, and how to do. I never did liver resection before in my life. So how to do liver resections. I saw CUSA for the first time, to be very honest with you. And all these things had happened there, but I put my notes. I read a lot of radiology, liver radiology also, because to understand the radiological anatomy is also very important. So downloaded so many articles and then read by myself, because there was no teacher in a radiology part. So everything you have to do alone, because there was no other support available to me. So once I came back, and then I asked Dr. Trivedi to have a software for it. He was kind enough, and he procured software costing 25 lakhs rupees in those days, right, where we can do the virtual liver resection. And that program was installed, and then he sent the radiologist also to Delhi, Gangaram Hospital. I think. Excuse me. Just. But I think. Yeah, but I think this is a very emotional thing, and it has given me the boost to go ahead with the more living donor liver transplant. Till that time, because of the fear, because of the limited knowledge, and because of the no infrastructure which we had, enough infrastructure, I mean to say, we were not ready for living donor liver transplant. But by that time, everything has happened. CUSA was also, I mean, CUSA was brought just along with this software for the virtual resection. So that exposure to Asan was very, very helpful, and we could go ahead with the transplant. Few patients developed, we found out the septic complications were not uncommon, and a lot of intensive care unit is required, and we didn't have the aggressive intensivists for that. So by 2014, I started 2 fellowship program. One is one with the help of anesthesia, the 1-year fellowship in liver transplant anesthesia and critical care. And second fellowship will be in abdominal organ transplantation, because nobody was interested in making in their career only in liver transplantation. And we were doing not many liver, like 20 or 25 liver transplant a year. So it was not a very large volume compared to what the big centers are having. They do about more than 100, 150 liver transplants. So they run the fellowship. Who will come here? So I thought that let me give the comprehensive care of a kidney and liver transplant both. So we started, and by that time, by 2015, our institution is promoted as a university hospital now. So it itself is given a status of university. So Kidney Institute become the Gujarat University of Transplantation Sciences. So we had a bigger opportunity to grow in a various thing. Also in 2012, I sent my colleague to UK and for the development of pancreas transplantation. So he returned from Oxford, and then 3 months later, and then he started doing occasional pancreas transplant also, though we are not in a large number of pancreas transplant surgery right now happening, but maybe a couple of or 3 or 4 cases a year are happening right now. And that will usually go with the kidney. So kidney, pancreas one side, kidney, and then the liver on the other side. So I think this is how stepwise we planned out. Living donor program took long time to develop because we were scared of donor, and only strict stringent criteria were applied, like not more than 50 years of age, and so many other things like and the LAI criteria and other thing. So we were not compromising anything in it, because anything happens to the donor, I know the program can get shut down completely. And there are, whatever you have done till date, nobody is going to remember. People will remember only that that a normal individual who is a donor who died, and then your license is gone forever. We heard all these things in I mean, some of the international centers also. Certain things had happened. We were very choosy about it. And then also second thing is in a pediatric, I did not have any committed pediatrician or a pediatric hepatologist or somebody like that who can look after the children after transplant also. So I decided not to go for transplant of a very small kids, like less than 5 years or certain things, because biliary atresia being the commonest thing, but we didn't go for it. Reason is that we don't have setup, and I don't think I can do without a proper setup to do such type of transplant. So I think then after the program was smooth, we started fellowship. Few fellows stayed with me, few fellows left the institution after about a year or so. Somebody stayed for 6 months, and then I had 6 fellows till this time, and all of them are well settled in a liver transplant program only. And my last fellow who become the associate professor up to me, and he's leaving tomorrow. That tomorrow is the last day for him, like that. So he's a associate professor we made him up to that level. He's since 2014 with me, and he's now going in private practice. So again, I'm left alone at this point of time with the Vaibhav is the one guy who is helping me. But the number of patients increased tremendously in recent time. And they were dying without transplant. Either you do transplant, you may have a less success rate compared to what the best of the best transplant unit are doing it. But if you don't do the transplant of those patients, they are going to die for 100%. I mean, that's the reason. So then and they were not ready, even though they were poor, they were not ready. I mean, spending the money is out of question. But even the organ donation awareness was not there among themselves. So we tried to make them organ donation awareness, but they were not ready to donate to their beloved also. But that's fair enough. And the best option was to collaborate with the other institution to develop the good deceased donor transplant program. By 2019, the Gujarat government has accepted to become the state organ and tissue transplant organization, SOTO. And I was made a convener of the SOTO, considering my interest in development of deceased donor transplant program. So I collaborated with the civil hospital. We are in the same campus, and talked several times to the superintendent of civil hospital. Initial there was a inertia, but later on it has been picked up, and now unbelievable work is going on at this point of time in civil hospital as a organ retrieval center. Like in a month's time, we procured 11 organs from 11 deceased donors in a last month or so. And the program has picked up like anything. Often all organs were not utilized, especially logistics problems, COVID time. So many things came in between. But then the deceased donor program improved upon. Even pediatric donors we accepted. We did a pediatric donor to pediatric, deceased donor to living, pediatric recipient transplant, so many things. And the program has really picked up.
Right now, Ahmedabad is leading in the donation?
Yes, Ahmedabad is leading in the donation. Previously, it used to be Surat, but now Ahmedabad is really doing very well, especially in the government medical college, and civil hospital. There are a lot of organ donations happening. Interestingly, looking at that part now, the other medical colleges are also feeling pressure about it or feeling about it. No, we should also be the part of this. So if the public sector hospital participates into this process, then certainly the number of organ donation, transplants are going to happen. Let me tell you, in a several in a last few weeks, like there are several weeks happen, we had 4 consecutive liver transplant. So I didn't go for 4 days to home, like, because just procured the organ transplant. By the time second liver is ready, I used to read Starzl's book and his movie also, like that 5 livers are just lying down outside his OT, and then they have to do like that. That scenario I could see in my own hospital also. So there are 3 liver, and then you have to really work very hard, and we have 2 OT only available, and the work 2 teams are going to work. There are no enough manpower. Anesthetists were shouting. Everybody is nurses are tired, but the surgeon keep on doing that job also. And then that was the best way to train the juniors also. So this is how it has been established, and now it is a really a very good sign. Only thing is, more livers are available, we are less number of people to carry out the liver transplant, because the salary issues and other things are always there when it comes to do such type of things. But I remain committed there, and it is happening in a government setup. That is the most important thing. We're planning to have applying for the program at the national level also, MCH program, if in case the hepatobiliary surgery and other things, if it is possible to do if NMC approves, then the things will be much more simpler to carry it out. But and we also have established now the full-fledged living donor program. We accepted little more like expanded criteria, we can say. We started doing taking middle hepatic vein now completely. We leave behind around 30% of the remnant liver volume. Previously, our cutoff was 38, 39, not less than that by any means. But now we are going down and down. We take the modified MHV, all these things like segment 4B, non-preservation, while segment 4A, all these modification which are described, which we have accepted and started doing practice about it, and learning more and more modern thing about liver transplant. So that is about technical aspect.
To your mind, how much does the liver transplant cost? Do you actually ask patients to pay, or how is it done?
Yeah, as far as the finance is concerned, we have a PMJY scheme. So that gives you 5 lakhs rupees per person in a family. In a family per year. So that money are used mainly for at the time of liver transplant, and then the state government also helps to some extent. They do 50% concession in some of the medications, and sometime with our request, then ICU care also is waived off by the director's office and other thing. We get a lot of philanthropic things, while donations come, and the money are used for the patient's care. So in that way, the overall cost of transplant is between 7.5 to 8 lakhs rupees in most of the patients who are uncomplicated transplant. In a complicated transplant, it varies, we know. And by and large, the hospital stays around, for a donor, it is around a week, and for the recipient, it is around 3 weeks time, most of the patients. So this is what it is. An immunosuppressions, then it has been included in one or other scheme, government scheme. So they get generic drugs free of charge, and in further admissions also occurs. Yes, they do have to pay for because if their budget is not there, government scheme is exhausted. So at that point of time, they have to pay something, but usually some amount of concession is provided by the institute itself because of its generosity towards people generously give the donation to the institution. So in that way, it is helpful, and they have to spend maybe still around sometime 50,000, sometime up to 1 lakh rupee for the transplant, and then immediate post-operative care. because every patient may not be eligible for the all kind of concessions given by the government. So this is
Are
what
you still
the
continuing with
story is.
kidney? Your kidney work is still continuing, or you have totally
Well, in a last 6 months or so, I stopped doing kidney. I was doing robotic kidney transplant, and I have done more than 600 robotic kidney transplant also. And we were the world leader in robotic kidney transplant. But looking at I think that is just a technical scholarship, but nothing more than that. And here, if the deceased donor transplant program improves, it improves the society as a whole. So there is the patients who are dying otherwise, right? Rather than having fancy things, just you do the open operation is also good enough. But here is the liver program development is opportunity in the life, and so I quit that program in last 6 months. And practically speaking, and yes, occasional case I do it, but that is occasional. Which I used to do a regular kidney transplant, which is no more. I'm practicing.
And tell me something about how you are able to manage without the presence of other supporting specialties under the same roof. Like, for example, for liver transplant, you need so much of help from cardiology, that you need help from pulmonology and other things.
Yeah.
How do you manage? From the civil hospital they come?
Yeah, it is like mine is a campus, civil hospital campus. In that there is a separate cardiology institute. So all the patients are referred to the cardiology institute there, and pulmonary part usually is looked after by the anesthetists themselves. And if we need help of infectious disease or so, we take the help from civil hospital by and large, like whether tuberculosis or any other thing is present in the lung. The differential diagnoses are so many, and then we take the help of the specialist available in civil hospital. So in that way, yeah, it takes little more time because you don't have in-house doctors available. So, yeah, so it takes more time. But I think, and I think in 2018 we got a hepatologist on board. He was from ILBS, and whenever we call him, he help us out in this thing, medical management of the patient. But otherwise, he's busy with his own private practice. But as and when, yeah, he's in private practice. So we take his help. Is Dr. Tanmay Vyas? We are taking his help right now. So he comes, and every Tuesday we have a common meeting. All anesthetists, this like multidisciplinary team approach. So all patients are discussed on given day, and we decide about the elective transplant or fitness about the recipients who are on a waiting list, top in a waiting list. Currently, we have about 60 patients in waiting list at this point of time, and hope that that number we can do that many transplant right now.
So how the retrieval logistics, how do you sort that out? Initially, so you did everything yourself.
Correct.
Now,
yeah.
How do you sort that out?
So I trained to my urology colleagues, because they were the only doctors who had an interest also. So I trained them to procure all organs. The heat which I got, the first heat that you cannot procure the liver. So first thing I decided that everybody should procure every organ. Right, there is nothing like the procurement surgeon should not have limitations only for the liver procurement or a kidney procurement or a pancreas procurement. They should learn everything. So we established that thing first with the urology consultant, and then with my fellows in a liver transplant program. Now they are procuring all organs also, and I'm also, whenever the staff keep on changing, so we train all of them, and all of them are very much keen to learn the multi-organ procurement. So at this point of time also, whenever the urology assistant professors, they are joining fresh or so, they are mainly joining for learning the kidney transplant aspect, and also the multi-organ procurement. So we teach them, and then they help us each other. So even today I go for the procurement, but usually not in a peripheral part like Rajkot or Surat. I just focus mainly on civil hospital. I stand there and then allow the youngsters to procure the organs. And then if they need me, yes, or that some complication occurs, I do join them. But this is how the situation is. And then my job has reduced significantly. Only thing is, since I'm the convener of the state organ and tissue transplant program, it's a lot of night hours work. So several sleepless night, and I don't. So 2 years now has happened, and I think I should retire from that particular job because it is too hectic for me to keep a balance in administration on a clinical side, and also to work in the night hours for the SOTO, because most of the donations are happening in the night hours also. So it is too much, and then yeah, not having any family life because of such type of things to happen. But yes, it satisfies you, and maybe after some time I have to make a major decision about it, that enough is enough, and we need to focus only on a clinical aspect, and before I get retired.
How do you think, I mean, what proportion of your entire, the success of the program depends on a government which is conducive and helps with the legislative aspect of things? How much do you think the government has contributed in this process?
Legislative aspect means that no, I didn't get exactly your questions.
What I'm saying is, how much do you think is the government responsible for the success of this program?
Well, it is because government has given me the responsibility to develop it, and I am satisfied at this point of time. Yes, we have done, and they are supported. Government is supported clearly to develop this particular program. So I mean, government always puts some people, and then if they are not doing that work, then program will not grow up. Fortunately, here they have put the transplant surgeons himself to carry out this particular program. And we had a passion to develop the transplant. That's how the liver transplant has emerged. We had a passionate director in the past. So that's how the kidney transplant program has emerged. So several things like depend on the people who are working in government hospital itself. And we never bothered to work in the night hours. Even I'm 54 right now, 55 is running, but still like we work in the night and day, both the times. Like it's not like that we can't do emergency because we are professors now, etc., etc. So everybody has worked hard, and the government has reciprocated positively every time whenever we do such a good work. And credit goes to the government and our institution also. And this is the single most institution in the state where the public sector hospital, where the kidney and liver transplantations are happening. So there is always a focus on it, and then government want to take credit about it also. So definitely they give us the right hand.
And I mean, I'm just asking you a controversial thing. You know, there is a difference between how UK plans its transplant programs and how the Americans do their transplant. The Americans usually have a transplant focus, which is organ specific, whereas UK, it is mostly the HPV units which take up the job of doing a transplant. So do you think, I mean, your model is something reflective of the American type of approach to transplant? So between the two, do you think there is any advantage, disadvantage, or do you think your model is applicable to our country as well?
It's to be very honest, I did not adopt any model per se, but whatever the opportunities are given, just we have created the history of doing the transplant, right? And to establish by urologists the liver transplant program to the extent up to this level is itself a challenge, I know. The thing is that who is interested in doing the work? Like you have fellowship, your own colleague will not allow, I mean, they put criticism also. Like my own friend told me that you are not doing a good justice to the medical profession. You are a urologist and doing liver transplant. Like I said, okay, anybody can come and do the liver transplant over here. Please do come, join as a full-timer, and because you require a commitment for the transplant. It is not fit and forget. After transplant, you have several hours of sleeping with the patient only, and then to look after each and every point. So if you're committed, you come. He was a cancer surgeon, but then he just said no. After 1 year, he called me, I want to join your team. I said, you come, welcome as a full-timer. Whether you're a cancer surgeon or you're any other surgeon, it doesn't matter. right? It is just, it's a passion for transplant. You come and join, but surgeons are surgeon. I believe, like government of India has also put a 3 years of training in a liver transplantation, means they can do then after the liver transplantation. So in the transplantation of human organ rules 2014 as clearly mentioned those type of things. So I mean, it's not a model. I'm still far from accepting any model. I'm just interested that people should have interest in join in transplant program, irrespective of their branches. A plastic surgeon wants to join and do, welcome. A vascular surgeon want join, anybody can do. Only thing they need to learn not only the technique of transplant, but understanding the physiology of transplant. Once that is learned, it is not a difficult, and it takes usually 3 years time to learn. So answer to your question, like I believe anybody, any surgeon, general surgeon, who should be passionate for transplant and wants to make their career in transplant should join the transplant, whether it's kidney, liver, or multidisciplinary pancreas, all abdominal organ. My branch is just abdominal organ transplant. So to do a pancreas transplant is not difficult. Only thing is like you need to know how to diagnose pancreatitis, post-transplant, graft dysfunction, etc., and the science behind it. So technique of vascular anastomosis, once you master, you can do any transplant. That is not a issue. Handling of the organ and the understanding the functions of those things and dysfunctions of the organs, once you learn biopsies, reading pathology, I think a younger generation, if they pick up, they have a long career in transplant. Person like me who has started my career in a liver transplant at the age of 40 years or so, may have a short career in transplant. That is very clear because it's very taxing things. You get a lot of gray hair very soon. So that is what liver transplant is. But I believe if we can stimulate younger people and allow them to work and to join and to do independent transplant, we may get some failure. But like, yes, the confidence level get up with the when we involve them very early age, and then probably we need a lot of transplant surgeons. Where are the surgeons? We really require a lot of transplant surgeons to look after this thing. So that's the model which I adopt right now, rather than going for any particular country's model.
So, did you have any problems or setbacks during the COVID pandemic, or you continued with your work as before?
Yeah, correct. Of course, it was closed. All transplants were closed during the peak time of the COVID. So, including kidney, liver, everything was closed. And second thing is, our few recipients were otherwise healthy, nice functioning graft. They had a COVID, and a few of them passed away also. So this was the biggest setback during COVID time, and at least I remember 7 patients died because of the post liver transplant because of the COVID itself. They were doing otherwise normally. So I think that is the most satisfying part. Is now like today only morning I went in around, and it was a holiday today. Suddenly a patient came, sir. I have to have my medicines because it is all over. So when did you undergo transplant? She said 12 years back, and that satisfies you that yes, patient comes 12 years back after after transplant to you. So I think we need to forget about COVID. So many things has happened. Everybody has lost something in COVID time. Somebody has lose the family member, somebody has lose the donor, and whatever. But I think it is important to come out of that and give them the best life.
Yeah. So I would end by asking you about what do you have in mind for the future for your unit?
Yeah, looking at my work, one industrialist is interested in establishing the Liver Institute now. He has offered to give 100 crore rupees establishment for the Liver Institute establishment. And I put it a proposal to the government right now. And the government is working on it and thinking about it, how to go for it, right? And if it is possible, then probably we will, like you have ILBS one as an exclusive liver institution. We may have the things in Gujarat also about the replica of ILBS, I can say. And then Yeah, and the model should be a little different because of the financial issues, many scholars are not joining, and if the government approves that type of project, then probably it will be the beautiful thing to happen in Gujarat as far as the liver diseases, patients suffering from liver disease is concerned, and maybe we can have one of the best liver transplant center in the country with the cheapest, lowest cost and good outcome.
That's great. And
Yeah.
like going forward, I would like you to share some, iconic photographs of your department. Something with your, say, I believe that Dr. Trivedi was very close to Starzl. So there were
Yeah.
some initial parleys between. Starzl has probably only visited Ahmedabad in India.
Yes.
Nowhere else.
Yes.
So you may have some photographs to share
Yeah, but
from your
no,
unit.
I don't. I can procure
Send it
for
on my
you.
email. Send it
Yeah,
on my email.
certainly. We had the first patient. Just story I forgot to tell you. The first successful transplant which I narrated to you. At that time also we had a transplantation update meeting, and Sir Roy Khan visited to IKDRC at that time. He was one of the speaker. And then Dr. Trivedi asked him to visit that since it was a first transplant, we wanted him to put some comment about it. So the patient was in ICU, extubated on the same day, and in the afternoon, Sir Roy Khan visited. I have that picture with Sir Roy Khan, and Dr. Trivedi asked, what do you say about this transplant? So he commented that if your patient is extubated, that means you know how to do transplant. It was a sardonic comment also, but it was at the same time blessing to us also, that yes, you know how to do the transplant since your patient is extubated. So that is the first one comment which he put it, and then we all smiled, laughed, and then disappeared from that place. But I think just we put every time I quote this when the new fellow comes, and then we got a transplantation. The next day, patient is extubated in ICU. That we said that is what I remember Sir Roy Khan, that this is what these were all his words. If your patient's kidney is functioning, patient is extubated, means graft is functioning. You may not look into the liver function test, right? There is no meaning of seeing on very first day the liver function test in that way. So just we had a discussion like that, and I have that photograph where Dr. Guru Prasad, who was my anesthetics, he's also there. Dr. Trivedi is there, and I think Sir Roy Khan is there. That is the iconic photo I have. Probably you can send it to you.
You can share that. Yeah, very great.
Certainly. Yeah.
And any message for other emerging programs in the government setup that you probably would like to share?
Yeah, just it's like you don't have to restrict yourself anytime. Just keep on doing it. Whether it is a government setup or it is a private setup, it doesn't matter. There are restrictions in the government setup, and but if you are a hardworking person, one father figure will pick you up and allow you to do the great work. It may take several years' time, and but you have to be persistent with it. Failure is a part of life. Nobody is 100% successful. Even God is not 100% successful. And so how can we be? But then, yes, you have to have passion. You have to have a commitment for your own work. And the patient is in the center rather than anything else. If patient is in the center, right, and no need to have very fancy things in the life. Like you don't have a luxurious room in a five-star style of hotels, special rooms like that. What do you do? Because they're hospitals, they are not the hotels. So I tell to my patients, if you are interested in such type of things, please go to those places, right? Don't come over here. But if you have interest in carrying the patient, I mean, overall simple whitewashes are there, then there are hardly one small TV is there, and things which are necessary for the life and care of the patient. This is only facility available at my room or my institution. If you are interested, we will look after you. So, and then that works. It's not like that it doesn't work, right? It does, it works equally. So just it's a time that don't feel inferior about it, that where I am working. People try to put it, it's a government sector, it's this sector. Nothing is inferior. I think it is all your courage, your passion, and your timeline. Yes, sometimes, yes, you get frustrated because what you want to do, you are not allowed to do, or you are not able to do because of the lack of equipment, instruments, and the manpower, etc. But I think my message is very clear: never get disappointed. Just keep on doing it. God will bless us.
Thanks, Dr. Pranjal. I think we have
Thank you,
covered
Dr.
extensively your journey, and I'll be getting a transcript done and then probably put it on the newsletter for the LTSI for everybody to go through. Okay.
My pleasure. So much.
Thanks.
Thank you.
Thanks for your time, and please share your photograph with me on the email. Right?
I will.
You have my email
Yeah.
ID? You have my email ID?
I think so, but maybe you can send me on WhatsApp. I will just reconfirm
WhatsApp it.
please.
Yeah.
Okay. Thank you very much.
Thank you. Thank you.